to invite Susie to join us now with her talk for us today.
Thank you very much, Amanda, and thank you to IIH UK for putting on a really great programme today. So my remit is to talk about our most recent publication to do with the IIH Weight Trial. And I'm just going to get my slides up. Here we go here. And it was really to walk everybody through the trial. I think if there are any questions along the way, Amanda, you can shout out if you want, or we can do them at the end. So with any big trials, there's always quite a long-winded title to it. But effectively, what we were doing was looking at the effectiveness of bariatric surgery and comparing it to a dietary arm for the treatment of IIH. And it was a randomized controlled trial. And we'll talk a little bit about the trial design and how we analysed the results. There, of course, are very many people that have spent a lot of time helping with the trial, not least the fantastic patients that came into the trial and stayed with us all the way through. So it really is thanks to every patient that took part and all the clinical team, and some of the academics and clinicians are mentioned here, but there's actually many more, particularly around the country, that are not mentioned here. We don't have any disclosures, and what that means is we don't have any conflicts of interest with this trial. It wasn't a trial of a medicine, and of course we don't have any particularly interests in selling either surgery or Weight Watchers. And I think it's important to note that when I'm going to be talking about idiopathic intracranial hypertension here, I'm going to be talking about what we term the most common type of patient that we see. So we know that IIH is a spectrum of disease where some patients may not fit the sort of common clinical picture. They may have other causes, and they may not fit that sort of standard patient that we think of. So I was going to talk a little bit about the standard patient, because it's really important that the people that came into this trial are people that had papilledema, and they're also people that had a body mass index greater than 35. And why that's important is when we think of the context of the United Kingdom, bariatric surgery is offered to patients with a BMI over 50. And if they have a comorbidity such as diabetes or something else, it can be reduced down to 35. Now, idiopathic intracranial hypertension is not on that list yet. And one of the reasons to do the trial was to see whether there would be benefit in performing the surgery in patients that had an elevated BMI over 35. All the patients that came into the trial were diagnosed according to the international consensus of how you diagnose IIH. The majority of patients had headache. As I said, they all had papilledema. And I think Ben quite nicely highlighted in his question and answer there the need to characterize people that have raised brain pressure. And it's a really sensitive issue around the majority of patients with IIH. So we're talking of 90% of our patients recognise that there's modest weight gain associated with a diagnosis and developing IIH. We know from the previous Birmingham weight loss study and other studies that reducing body weight can be beneficial in disease remission. Now, that doesn't always get rid of headache, and we completely recognise that in Birmingham, but it does reduce intracranial pressure and the papilledema resolves. And so we've also seen in the literature where people have previously been diagnosed with IIH and it goes into remission, that they can get relapse, and that again can be associated with weight gain. And we've also just mentioned the PSP, And really one of the emphasis of our top 10 was really evaluating approaches to weight loss interventions. So our question when we were in setup of the trial many years ago was thinking that actually bariatric surgery may be better than a diet in reducing intracranial pressure in patients with IIH, mainly because you would have greater sustained weight loss. So there's two things there. You'd probably have a larger amount of weight being lost, but also that there wouldn't be the reoccurrence of weight gain, which has been shown in many, many studies with dietary interventions. This was a 5-year trial, so you can imagine that we started it nearly 7 years ago, but it was planned nearly 9 years ago. So it's been a long journey. Patients were recruited at 5 NHS hospital sites through neurology and ophthalmology and through the IIH Research Network. And we recruited women to the trial. And in essence, I think over the years, we have started to see more men get IIH. And at the time that we were setting this up, which was nearly nine years ago, we felt the best way forward was just to recruit women to the trial. So it does limit, in some respects, when we come to the conclusions of the trial, your entry criteria limit what you can say about the whole disease. So, as I said, we included women between the ages of 18 and 55 with an increased body mass index over 35 with a positive diagnosis of IIH. There's some exclusion criteria, and actually they're very similar to the trial that Ben's just talked about, including not including patients that have other eye problems and things like that, because we were interested to looking and seeing how the eyes got better as well. We randomized patients 1-to-1, so that means at entry to the trial, it was a flip of a coin whether patients went down the bariatric surgery pathway, and that's important to say, a pathway, and I'll talk about that soon. And the other flip of the coin was for people to be given Weight Watcher vouchers. They were able to access all the online content. To talk a little bit about the bariatric surgery pathway, it's important to know that surgery is the last part of that pathway. In England, there's a clear Tier 3 weight management service where a patient will go in and they will be assessed not only by consultants, but also by psychologists and dietitians. And there's a whole multidisciplinary team who start out with advice and group support. And as patients move through the pathway with certain goals individually set, when they get nearing the end of the pathway, they'll have a discussion on whether they actually want to proceed with bariatric surgery. And at that point, they will have a discussion around the type of surgery that they're going to be offered. And we kind of felt that it was more pragmatic, not to say, right, we're just going to use one surgery, but allow the patient themselves to talk to the surgeons about what would be best for them. So in essence, there were 3 types of surgery in the trial. There was something called a sleeve gastrectomy, there was a laparoscopic band, and there was also the Roux-en-Y gastric bypass. And to sort of put things into context, in the past, these surgeries, people would be admitted for a long time to hospital. A laparoscopic band can be fitted in a relatively short period and the patient's home within 4 hours. And the Roux-en-Y, generally the patients went home the next day. So these surgeries now are much better tolerated. And there are differences, and we will be talking about the differences in some of the later work that we're going to publish at the end of the year between the types of surgeries our patients had. When you set up a trial, you need to pick something to say, has the treatment worked, or what's the difference between 2 treatments? So the outcomes here that we took, where you choose a primary outcome to what we say is power your trial on, and I'm going to talk a little bit about power calculation in a minute. and we were looking at a difference in intracranial pressure between the surgery group and the diet group. So that's lumbar puncture opening pressure. And we were looking at it at 12 months for the primary outcome. And then we set secondary outcomes, and that includes not only lumbar puncture opening pressure at 2 years, but all those visual tests that you do in clinic plus a wee bit more. We look at health associated quality of life. And importantly, we have to think about cost effectiveness if we're going to be able to support the evidence for the NHS. So we have to show them it's cost effective as well, because we're in a national health service situation. And our patients were fantastic because we had to bring them back a number of times to keep them within the trial, to really work out how well the results would pan out over the 2 years. And we also have another 5-year visit coming up, and it's more than likely in the future we will follow them up with NHS Digital out at 15 years and beyond, because it's important to see that when you give somebody a treatment that it actually works over time and for the rest of their lives. So we had to decide how many people do we need in the trial, and this is really important because setting up a trial and running trials is actually incredibly expensive, and you have to justify every test you do because it costs money. It's not just NHS care, and we need to work out how many people we need in this study to make sure that we see the difference between the two groups, if there's going to be a difference, or if there's not a difference, that we've done enough patients to show that there's not a difference. So we call that a sample size calculation. And you do it based on previous studies, and you also have to do it based on how many people you think are going to drop out along the way, because there's natural dropout, and you need to account for that. So this is a bit of a wordy side, and I don't really want you to worry so much about the words, but it's kind of are working out on paper to say, the differences that we wanted to see between the surgery and the diet arm. And we plan to detect a difference of 5 centimetres of CSF on lumbar puncture, to really see whether there was going to be a difference between the two groups. And we had to work on a 28% withdrawal rate, and that was based on our previous trials. So based on this calculation, we knew we needed 66 women, where 33 women would go down the surgery pathway, and the other 33 women would go down the dietary arm. And you can analyse trials different ways, and there's something called intention to treat, and there's something called per protocol. And this is important here because you have to set up how you're going to analyse the patients before you do the study, so you're not biased and you don't sway one way or the other. And what intention to treat means is that when we randomise you to a group, so if we randomise you to the surgery arm, you will then always be in the surgery arm whether you receive surgery or not. So it's an intention to treat, and it's a balance, because you can see that some of our patients decided not to have surgery because it wasn't right for them, but they will still remain analysed in that arm. And some might say, well, that's odd, because if they haven't had the surgery, then they're going to cause noise within that group. And so there's another way to analyse, which is called per protocol. And how you set up trials is to do the analysis as best you can, and we plan to do a per protocol analysis. And what that means is that if you had surgery, you're analysed in that group. If you didn't have surgery, you're analysed in another group. And that some of the data from our per protocol analysis will be coming out hopefully later this year. So the results were that we definitely randomised 66 women. It was a very popular study, actually, once we opened, so we didn't have to screen too many people to get our women through. But you'll see from the numbers there that 27 people had surgery and 6 people didn't have surgery in the surgery arm, and we had some patients that withdrew from the Weight Watchers arm, and that just kind of shows you moving through that the numbers do get smaller when you get to 2 years. You miss little bits of the analysis. But for any patients that were willing to come, we would have taken their headache diaries and their quality of life and their eye data, even if they didn't have a lumbar puncture. And we saw that what we would expect. So we set the trial up to have what we would say is somebody who'd be very typical to have IIH, somebody who was 32 years was the mean age. They'd had IIH for about a year. And so these weren't acute patients. They were patients that have had the disease for some time, but still had quite significant papilledema. And the lumbar puncture opening pressure was high at around 35. So this would be, a very nice group of patients to really take forward for the study. And I talked to you a little bit about choosing that number to show the difference between the two groups. And you don't need to worry too much about the graphs and things like that. But what I'm showing you here is that we wanted to detect a difference between the two groups of 5 centimeters of CSF, and actually we detected a difference of 6. And so that met our primary outcome, and that means that the results are statistically significant. So there was a statistical difference between whether you were in the dietary arm or whether you were in the surgery arm at 12 months. And there was also a difference between the change in intracranial pressure in the surgery group here. This is what I'm showing you. And the difference was of nearly 9 centimeters of CSF on lumbar puncture opening. So the surgery arm was very effective at reducing intracranial pressure. And as you can see, this is now the diet arm, and there wasn't much difference between the two lumbar puncture opening pressures from baseline, the first time we saw the patients, to 12 months in the study. And then we wanted to see out at 24 months, were we able to sustain the difference in reducing intracranial pressure? And absolutely we were. So there was a difference of 8 centimeters on the lumbar puncture, which was excellent. When we moved through to look at some of those secondary things we wanted to look at, we wanted to look at all measures of weight, BMI, and reduction in excess body weight. And these were all much more significantly seen in the surgery arm compared to the weight management diet arm. And this just kind of shows you the percentage change in body weight over the trial. The dietary arm didn't have a significant change in their body weight, but obviously the surgery arm had a really large proportion of over 24% weight loss. And this is just really nice reflected in the percentage change in the lumbar puncture opening pressure. So that surgery arm really shows the fantastic reduction in intracranial pressure. And you might say, well, why has there been a change in the diet arm? Because it doesn't look as though we lost an awful lot of weight there. But if you sit in clinic with us, you'll realize that over time, for some people with IIH, things tend to naturally settle over time. And that's because there's a disease spectrum. So some patients have mild disease and other people have more serious disease. And that's kind of reflected in any medical condition that people have. So moving through, I said that, there were many secondary outcomes we looked at, and I'm only presenting a little bit of data here, but we did see significant changes in our quality of life, which is really important, because once you are able to show that there's benefit, holistically to the person, and if it's cost effective, then you have a higher chance of getting it funded on the NHS. We're always asked about in trials, were there problems with the surgery? Through the course of anybody's illness with IIH, you may all recognise at the start of the disease having admissions to hospital with exacerbation of headache, really bad headaches. But it was really important to show that no patients had to undergo emergency surgery within that first year. We did have one patient in the diet arm that had a deterioration of their disease and unfortunately had to have a neurosurgical shunt to save their vision. As far as the bariatric surgery was, it appeared to be a very safe and well-rated. We did have one serious adverse event with a patient who ended up being admitted with vomiting, and it was found that there was a mesenteric stitch. It was taken out and they were home within 4 hours. So, you know, although it's clocked as a very serious adverse event secondary to their surgery, it resolved very well, which was excellent. And we've always got to report that there were no deaths in the study. At the start, when I talked to you about the trial, I said, you know, in any randomized controlled trial, you have to ask a very specific question and you get a very specific answer back. So these were women, they were patients who had a BMI over 35. So it's very difficult to say, to generalize the results to patients who have a BMI under 35. But what we do know from the surgery literature for bariatric surgery, and particularly in patients that have other conditions like diabetes, they do very well between a BMI of 30 to 35 in terms of their metabolic health. So although we can't recommend it for IIH based on the results of this trial, it'll be interesting in the future to look at that. So I know it's quite a lot to take on because it's quite a big trial, and there's a lot of information there. So I just wanted to really pause there and think if there's any questions that people want to talk about. I've got some of the acknowledgements, and I know at the start of the talk I acknowledged you know, the patients, but we really are indebted to our patients that come from far and wide and really go the extra mile to be able to help us work out how best to treat IIH. So I'll just stop sharing there and see if we've got some questions in the chat.
Hi Susie, thank you so much for your talk. Enormous thank you for sharing the results of this very important trial with us. I can see a question in the chat for you which asks about they're interested in the group of people who started in the surgery arm, went through tier services but did not elect to have surgery. Could you talk a little bit more about the reasons for dropouts?
In research, we don't technically ask people why they are dropping out because it's a personal decision. We don't want to influence our patients. I can think that there's probably multiple reasons why people get to the end of the pathway. Maybe they've lost enough weight that makes them comfortable. Maybe you know, there are many things around bariatric surgery in terms of how it changes your attitude to food and lifestyle, and culturally for some people that's not acceptable. You know, so I don't have any individual stories to really kind of highlight, but in the years that Professor Sinclair and I have worked together, and the number of times we've talked to people, those generally are the reasons. I don't think when people come into the study, you're meant to come in saying, I don't mind whether I would go down the pathway for surgery or I'd go down the way for diet. But I guess once you get in that pathway and you learn what the risks are and what the benefits are, and you're given time to think about it and have experts talk to you about it, I guess there's going to be a few people that decide that it's not for them.
Yep. And there was a question in there about the whether you have any information about the general benefits of tier 3 services.
I mean, I think the general benefits really are clearly linked to the fact that these are experts. And I know you're going to talk a little bit later on, Amanda, about obesity stigma and talking about weight management. You know, as doctors, we've not been trained. I'm an ophthalmologist, my colleagues are neurologists, and you know, we haven't been trained. We've picked up tips and tricks. We've obviously done as much self-education as we can. but the people in the weight management service, this is their expertise, and they're not just telling you the recent diet they've been on or how they've managed to succeed. So I think it's the wealth of their knowledge, and also the fact that they approach it from lots of different angles, and particularly I think with the psychology input is incredibly important for some people. So.
Okay, thank you, Susie. There's another question here about the links between IIH and weight, and as to whether the distribution of fat that somebody may have and the effects of hormones.
Well, I think that's a fantastic lead in for Professor Sinclair, because I think that's exactly what she's going to be talking about. I think the translational research that Professor Sinclair and the academic team have been doing here in Birmingham is really starting to unpick this and really get to the root cause of why IIH affects people and why there are some people that have weight gain and they don't get IIH. So, you know, and it's definitely going to be the crux of her talk.
Right, so we won't
steal
Alex's talk. That's fair. That's great. I'm just having a look to see if there are any other questions in there for Susie. I think that's all the questions for you, Susie, that are in there at the moment. Susie did a fantastic explanation of some of the research methodology as well. And it's something that we're hoping to share more with people with IIH, is actually to help people understand the methodologies that people are talking about. So it's certainly something that we're expanding on with the support of healthcare professionals like Susie and Professor Sinclair on the IIH UK website. Just there's a couple of, oh, okay. There's another question in there. Has this study been sent to bariatric services across the country? That's a really good question.
It's a brilliant question, and actually it almost doesn't work like that, unfortunately. So we have registered, and I think IIH UK have registered with the National Institute of Clinical and Health Excellence. We've also got the UK Neuro-Ophthalmology Society, and you heard from Dr. Wong earlier on today. She is our Vice President and Chairperson for that. So we are going to start lobbying. It's over a 2-year process that the NICE are currently reviewing bariatric services for England. We have little jurisdiction in Wales, Northern Ireland and Scotland because of how the NHS is set up, but we will certainly be at the forefront from lots of different areas. So it's important to get the professional groups to engage experts like ourselves to engage, and also IIH UK.
Yeah, absolutely. And just to add to that, is that we've also joined the All Parliamentary Group on Obesity as well, which is another way that we can potentially lobby nationally to get important research like this included into guidance in the future across the NHS and from a government perspective as well. So, so hopefully that's something that we can all work on together. Okay, I think that's all the questions for Susie that are there. So we've just got a little 5-minute break now until we welcome our IIH UK patron, Professor Alex Sinclair,